Well, good morning, everybody. My name is Trevor Schell, and I'd like to welcome you all to OHCOW's 26th annual RSI webinar series, focused on the recognition and prevention of musculoskeletal disorders. RSI Day has grown to become the world's largest ergonomic-focused webinar series, which is illustrated on the map you're seeing on the screen right now. Today, we have unique registrants from a record-breaking 57 different countries. Each year when I'm reviewing the registrations, I can't tell you how excited I get when I see a person from a new country registering. When we began RSI Day locally, we had 20 people in the basement of a local union hall. And from that, it's grown to become a truly global phenomenon. Now, our first presentation today is a joint presentation with myself and OHCOW physician, Dr. Cynthia Arnold, on osteoarthritis of the CMC joint.
So good morning, everyone. I'm excited to be here to talk about osteoarthritis of the first carpometacarpal joint. During the talk, I'll refer to this joint as the first CMC. And if I just say CMC, then you know I've made a mistake because we're talking about the first. Next slide, please, Trevor. So today we'll present a case of first CMC OA that Trevor and I worked on. Then I'll go over the anatomy of the joint so that we're all on the same page and understand what we're talking about. I'll discuss OA and specifically first CMC OA. I'll go over the non-occupational risk factors, and then Trevor will discuss the occupational risk factors. Next slide. So we had a 53-year-old male sheet metal worker who presented with approximately 32 years of experience. He presented with severe pain of his right thumb and wrist, and after about a year and a half, started developing some difficulties with movement. He was seen by his orthopedic surgeon who diagnosed first CMC OA. He underwent x-rays and ultrasounds which confirmed the diagnosis. He was treated with thumb splint, nonsteroidal anti-inflammatories, and underwent a steroid injection, which brought him about 9 months of relief. Unfortunately, repeat injections, and I think he had 3 to 4 over a year and a half, 2 year span, had much shorter duration of relief, and his orthopedic surgeon referred him on to a plastic surgeon for surgery. Next slide, please. So this is the bones of the hand. I think the one on the right is the best one to look at with the hand flat. We can see that the fingers have 3 phalanges. The thumb has 2. Then we go down into the long bones of the hand, which are the metacarpals. And then we come to the 8 carpal bones that make up the wrist. And we can see the first CMC joint as it's in that circle and it's highlighted. And we can see that it's at the base of the thumb. Next slide, please. This is just a better view to look right at that joint. In the green, you've got the first metacarpal of the thumb. You see the trapezium, which is the carpal bone, and then the joint there. Next slide, please. So this, the green in this is the articular cartilage. The long bone or the first metacarpal is seen there. And then it butts up against the trapezium. And then behind that, you see the scaphoid bone. And when we talk about CMC joint OA, it's the joint between the first metacarpal and the trapezium, but it also can include the scaphoid trapezium joint if there's arthritis there. Next slide. This slide just outlines the blood supply, and it's a simplistic view. The blood enters the hand from the ulnar and the radial artery, with the radial artery on the right side by the thumb. On the thumb, the superior palmar arch forms from the ulnar artery with contributions from the radial artery, and the deep palmar arch there is a continuation of the radial artery with some input from the ulnar artery. The thumb has dorsal and palmar systems. Both systems can supply the thumb with enough blood supply on their own. And you won't be surprised to find the dorsal system, it's the dorsal ulnar and the dorsal radial artery. And in the palmar system, it's the ulnar digital artery and the radial digital artery. Next slide. This is one of my favorite slides because it shows all the functions of the first CMC joint. So if you move your thumb around, you can see how many positions it can go in. So it's not surprising that severe pain from OA results in significant loss of hand function. I think people often underestimate the impact of hand OA in an individual. We're always focused on lower limbs, hips, and knees. But obviously from this anatomy, you can see that damage to that joint would result in difficulty in doing a number of activities of daily living. Next slide. So what is osteoarthritis? It is the most common cause of arthritis, and according to Johnson Hunter in 2014, 15% of the population has OA. Pain is a common presentation, often involves multiple joints. The inflammation seen with OA is modest compared to the inflammatory arthritis such as rheumatoid arthritis, psoriatic arthritis. We see changes to bone, ligament, cartilage, and synovial tissue. So you get narrowing of the joint space, loss of articular cartilage, osteoformation. Next slide, please. So when we look at first CMCOA, the hand is one of the most common sites of arthritis in the body. In 12% of individuals over the age of 50 in the UK have pain in their hands from arthritis. The first CMC joint is the second most common site of arthritis in the hand, and it is responsible for more pain and disability than other sites in the hand. This joint can present alone or it can present in association with other arthritis in the hand. And what are the symptoms? People usually present with pain at the base of the thumb. It's aggravated with movement of the thumb, such as pinching and gripping. So if you can imagine if they're using scissors or twisting off bottle caps or opening a jar, there'd be significant difficulty and pain. With progression, with osteoarthritis, the pain develops some weakness, decreased range of motion, and go on to mechanical instability. Next slide. So how do we diagnose this? Start with a clinical diagnosis, the history, just what we discussed. Where is the pain? What are the aggravating and alleviating factors? On physical exam, where is the patient tender? Is he tender over that joint? Is there any swelling? What is the range of movement of the thumb? Is there any weakness? Can you feel a bogginess in the joint? Is there an effusion? Some people think that a clinical diagnosis is enough, but if we look, most people go on to x-rays. And O'Neill and all in 2018 said that up to 50% of people had radiographic changes of osteoarthritis somewhere in their body, but they were asymptomatic. When we look at the hand, 21% of the US population has radiographic evidence of OA, but they don't have any symptoms. 16% have x-ray findings and symptoms. When we look at the first CMC joint, there's a higher association between x-ray findings and the person having pain and decreased strength. In the past, over the past 10 to 20 years, MRIs and ultrasounds have been used more. MRIs were initially just a research tool. And because of the use of MRIs, we know that most CMCOA is associated with ligament rupture and dorsal subluxation. In our case, our patient had moderate to severe OA of his first CMC joint with minimal OA in the rest of his hand. But his ultrasound showed a joint effusion and he did have subluxation. So next slide, what is the treatment? You know, we always like to avoid surgery, especially in elderly and people with comorbidities. So if we can avoid surgery and do a conservative treatment, that is preferred. Physio is popular, and there's some good evidence that it helps with pain in the first CMC joint. You can try oral and topical nonsteroidal inflammatory drugs, Tylenol for pain. Thumb splints are good at improving pain, but unfortunately, they decrease the function of your thumb. And steroid injections have good evidence of working, though there was one study that showed they didn't think it was any better than placebo. So when we have failure of the conservative, we go on to surgery. Next slide. And the primary goal with surgery is pain relief, but they also want to try and preserve some of the function. Occasionally they do a bone fusion, but most of the procedure, all of the procedures usually involve partial or complete removal of the trapezium. And they usually combine this with another procedure to try and save the joint space, such as ligament reconstruction and tendon interposition, an LRTI. If we look at what was done recently in the US, 93% of the US surgeons performed a trapeziectomy with pinning with an LRTI. It's considered a low incidence of complications, though, of course, there's always the risk of infection or the wound opening up or a complex regional pain syndrome or injury to the radial nerve. But basically, the surgeon and the patient decide the procedure. And they say one of the risk factors for someone not going to succeed with surgery is not going to succeed with a non-surgical intervention, a conservative intervention is a subluxation like our patient had. Okay, the next slide. So today, the current evidence in the scientific literature opines that it's the interaction of each individual's unique risk factors that results in the development of OA. So when we look at non-occupational risk factors, there's no doubt that age is the strongest predictor of OA, but no one's 100% sure why that is and what the mechanism is known. Females are much higher risk of developing OA of the hand, with a maximum fourfold increase compared to males between the age of 50 and 55. In females, the risk peaks at the age of 55 to 60 and then decreases. When we look even at the age of 85, there's still a 2-to-1 female to 1 ratio. Johnson and Hunter in 2014 looked at the Framingham study, and they found symptomatic hand OA was present in 26% of women and 13% of men. And in 2022, Raj and al. Looked at the age-adjusted prevalence, and they said 17% of men get first CMC joint OA versus 15% of women. So they were actually looking at our specific joint. Why does this happen? No one knows. Some people think it's the role of estrogen, but that hasn't been proven. Bone strength, the size, the ligament laxicity, pregnancy. Bottom line is no one really knows, but it is a major risk factor being female. Next slide. When I look at obesity, it's very controversial. There are some good evidence that there is an association between obesity and hand OA in recent studies, and they think it's secondary to metabolic and inflammatory factors such as metabolic syndrome, diabetes. But for everyone that says there's an association, there were many that showed no association. So I think I'm sitting on the fence on this one. I think the literature, it's up in the air. The one thing everyone does agree on is that approximately 60% of hand OA is secondary genetics. They also agree that previous trauma, such as the fracture, can result in OA developing later. Next slide. So in summary, there are factors we can't change. You can't change your genetics or being female, but there are factors that can be modified, such as environmental factors, such as work life. And all these factors interact to result in first CMC joint OA. Wigley et al. In 2011 discussed the misuse of the term degenerative, and he did this regarding a number of disorders, including osteoarthritis. Their philosophy was that insurance company used the term degenerative to mean age-related and to deny patients' claim. And our patient was complained, and part of their stance was it was degenerative disease. It wasn't work-related. So Wigley and all feel that risk factors such as sex, age, and genetics can predispose you to an injury, but an accident or an environmental change is necessary to cause the injury or the start of the development of osteoarthritis. So now we will have Trevor discuss occupational risk factors for first CMCOA and see if the patient's work history as a sheet metal worker contributed to his development of this arthritis.
Great, thanks. So, starting off with the occupational risk factors, grasping a prolonged pinch grip is actually one of the main risk factors that we tend to find related to CMC joint OA. This is because a pinch grip using the index finger and the thumb places a high degree of force on the CMC joint ligaments. Studies have shown that the force increases exponentially between the force exerted at the point of the fingertip of contact and at the CMC joint. As a matter of fact, it's actually 12 times greater at the CMC joint compared to the force you're exerting on the object itself. So, for example, if someone was exerting 10 kilograms of force exertion pinch gripping at the fingertips, there's actually the equivalent of 120 kilograms of force being exerted on the CMC joint itself. Gilbertson et al. Sought to establish normative data for adults between the ages of 19 and 92, comparing pinch and power grips. Regardless of which hand they were looking at, what was found was that the power grip was actually 4 times greater than a pinch grip. So by using your whole hand, you're generating 4 times the amount of force than using a pinch grip. They also found that using a pinch grip only allowed for about 25% of maximum grip strength to be generated compared to a power grip. Other awkward risk factors, awkward postures, for example, with adduction. So basically, in a pinch grip, having your thumb and your index finger squeezed together. This causes a slight change to the orientation of the bones, so they don't fit as well together. And there's more strain on the joint and the ligament itself compared to, say, abduction, where there's actually sort of, like such as grasping the larger book, where there's more space between the thumb and the index finger that allows that normal orientation of the bones to be maintained. Another risk factor is inadequate recovery, formerly known as repetitive motion. When Zeller, in 1996, stated that the thumb provides a stable post about which the rest of the hand may perform activities of a pinch and grasp. The special functions of the thumb can account for up to 50% of their overall hand use. Exposures to twisting, jamming, and contusive forces, as well as repetitive stress, is an everyday occurrence in the workplace. So this goes back to that sort of range of motion that Dr. Arnold was talking about at the beginning, that there's just, the thumb is so involved and so has so many different roles to play that, again, it accounts for 50% of overall hand use. Also, overall, repeated forceful manual tasks will diminish a worker's ability to produce required force like gripping. It also increases the risk of fatigue and injury. Continuous use of the hands and wrists will result in fatigue of the muscles. In turn, this reduces the muscle's ability to generate the maximum amount of force required to perform essential tasks. If a muscle group is not given enough time to recover between repetitive or continuous motions, muscle and joint soreness can escalate, leading to a cumulative trauma injury. And Nocella in 2011 stated that prolonged muscle activity leads to a reduction of mechanical power and force output, which is commonly indicated as muscular fatigue. The development of muscular fatigue during repetitive stimulation of the skeletal muscle consists of an initial phase during which the force would decrease by about 10 to 15%, followed by a second phase where the force remains almost constant, and then finally, the final phase where the force begins to drop to low levels. Now, static postures are another risk factor. Now, as Dr. Arnold mentioned at the very beginning, the CMC joint is an area of very low blood flow. Nutrients must enter the cartilage from the bone or from the synovial surface surrounding the joint. Static and often awkward postures reduce the blood flow to synovial tissues and also reduce synovial fluid circulation to the CMC joint. This results in less penetration of the cartilage by solutes and reduces the clearance of waste products from the joint, which highlights the dependence on normal loading patterns for the maintenance of a functional component. Tissue discomfort and fatigue will also often arise from having to hold the tense muscles in a fixed or awkward posture for prolonged periods. The cartilage doesn't have any capillaries. It receives its nutrients again from the synovial membrane. And the transfer of nutrients occurs when pressure is being placed upon the joint and during normal movements such as flexion and extension. Under pressure, the synovial fluid inside the cartilage is forced out, carrying debris from the cartilage. And as pressure is relieved, the synovial fluid will seep back into the cartilage, providing it with nutrients. It's very similar if we were to squeeze a sponge that's in a bucket of water. As you squeeze the sponge or apply pressure, water is sort of flushed out of the sponge. When you release it, water will seep back into the sponge. During static postures, the selected joints are placed under pressure for a lengthy period. Since the articular process main function is to absorb compression, it is forced to work the entire time, making it more susceptible to softening and degeneration. So this results in the bones having to absorb more pressure and increasing the risk of deformation and bone spurs. Also, as there is no pressure change during a static posture, no nutrients are being delivered to the cartilage. Therefore, no repairs can be made, which may increase the severity of damage to the cartilage. Another risk factor is contact stress. When gripping tools such as snips, shears, pliers, the point of application of the force is mainly directed directly over the CMC joint itself, very much like acting like a constant trauma to the joint. This not only applies direct pressure to the joint, but also onto the few blood vessels passing within the space. As previously mentioned, reduced blood flow has been linked to the development of osteoarthritis, especially with a joint such as the CMC that already has limited blood flow. Now, gloves, while providing protection from the elements and sharp metal, have several associated problems that have to be considered. If the gloves are too large, then a worker will often grip harder to hold an object, thereby causing more strain on the muscles. If the gloves are too small, they'll constrict the blood flow into the hands and apply pressure onto the nerves. This leads to reduced blood delivery to the muscles and numbness of the hands. Gloves also reduce the tactile or feeling sensation that one experiences when touching an object. As a result, the worker is required to squeeze harder to ensure they're grasping their equipment. As a result, exerting more force to perform the task places them at a greater risk of injury. Continuous exposure to vibration can also have multiple effects on the hand. The first being that vibration has been shown to have an effect on skeletal muscles such as tendons and nerves, or tendons and muscles. These effects cause local contraction of the muscles that are in contact with the vibratory source, such as a tool handle. That leads to muscle fatigue as the result of overstimulation. These contractions also lead to attenuation of the vibration signal to the affected areas. So when operating vibratory equipment with tense muscles, this can lead to an attenuation or amplification of vibration into the body. Now, Elsner in 1995 attempted to show the interaction of the majority of the risk factors on the development of osteoarthritis. So you can see on the left, we have hand-on vibration. The effect of low-frequency percussion causing that sort of constant contractions of the muscles. On the other side, the normal risk factors we talked about, inadequate recovery, microtrauma, awkward postures. These all act to cause dynamic and static joint loading, as well as the effect of low-frequency percussion, and add to that these sort of non-occupational factors that Dr. Arnold mentioned can all lead to contribute to the development of osteoarthritis. Now, with respect to prevention of injuries, each time someone experiences thumb pain when doing an activity, they need to stop and consider whether the way they're doing it is causing stress on the joint. They need to take notice of any pain they feel. It can serve as a warning that the way they're performing the activity is causing damage to the joint. For example, using a pinch grip when you're writing. One way that people can prevent stuff is to keep the top of the joints of the thumb bent and the wrist extended. For activities that involve turning or twisting, avoid fully straightening the top of the joint of the thumb and also the thumb crossing into the palm, which is that adduction that we talked about. Saying that abduction is beneficial. Spreading the load over several joints, again, carrying an item on two hands instead of one, and using the stronger joints rather than putting the strain just on the thumb joint. So again, using that power grasp instead of the pinch grasp, because again, it's 4 times stronger. An example of joint protection, carrying a coffee mug. Instead of just carrying the mug with your thumb, hold the mug with one hand and support the base with the other. There's going to be less strain placed upon the CMC joint. Another example is carrying a bulky item such as a pile of papers. With just one hand, we've got that large squeezing force happening. Instead, use 2 hands or hug it to your chest. So therefore, you're putting less strain on the joint. There's assistive devices for writing, because one of the most common things we do see pinch gripping used is when we're writing. So they have larger diameter pens or pen grips that all act to reduce the impact of pinch gripping. So while pinch gripping is still happening, it's actually spreading your thumb and index finger apart to get more of the abduction going on at the thumb as opposed to the adduction. It's also been shown that felt and gel pens actually require less force to write than a ballpoint pen. There's also other assistive devices around the house that people can use. An electric toothbrush instead of a standard toothbrush, water utensils, or placing foam around utensils to increase the diameter. There's a device called a button hook that instead of using that prolonged pinch grip to feed the button through the hole, you loop it around the button and pull it through the hole. And then other devices such as jar and bottle openers. With respect to tool design, you want to make sure you purchase tools with a wide handle diameter to avoid pinch gripping. Spring-loaded tools will help to reduce the force you have to exert. Rubber handles to avoid pressure points. You also want to make sure that the handle of the tools have the appropriate handle span for your hand size. As shown in the chart on the slide, as with awkward postures, the design of tools can also impact muscle force generation. This is illustrated by the effect of handle span on the ability to generate an effective grip strength. When the size of the hand and the span of the tool were compared, there was a large difference for the maximum amount of grip strength that the subjects could perform. A small hand about 200 newtons and a large hand about 450. There was also a large change within the hand sizes. For example, with the small hand, the maximal grip strength was attained with a handle span of 5 centimeters, compared to the larger hand, where the maximal grip strength occurred with a handle span of 6. Now, let's go back to our case study that we were talking about with our 53-year-old sheet metal worker. Bottom line, his compensation claim was denied because the ongoing diagnosis of osteoarthritis is degenerative in nature and therefore not compatible with your workplace injury. Well, let's look at sort of what he was doing for his job. The primary tools used by a sheet metal worker include shears, which are used for a long, smooth, or have a long, smooth cutting blade used for large cuts and are used to cut thicker or longer pieces of metal and are used for about 35% of the day. They also use snips, which are shorter and often have a serrated blade for smaller cuts and are used for fine, short, or curved cuts, often on thinner metal. They tend to leave jagged edges, which must also be smoothed with a grinder. They come in multiple designs for straight, left, or right cuts, and again, they're used for about 35% of the day. A grinder is used to smooth jagged edges and can be used for up to 25% of the day. And then other tools such as hammer drills or hammers are used for about 20% of the day. Now, what can become very evident very quickly about the tools, the snips and the shears, is that they're being held within the hand, a very common factor between all of them. So when being used, the pressure and application force occurs again directly at the CMC joint. So all the effort of squeezing, cutting, is applied directly onto the CMC joint, which again is 12 times larger at the joint than where the tool is actually being used against the object itself. A review of the patient's physical demands analysis basically resulted on average of risk factors using the upper limb, dynamic pushing and pulling force for about 35% of the day, hand gripping for about 83%, pitch gripping for about 40%, upper extremity coordination, 84%, vibratory exposure, 50%, and also glove use for about 100%. Additionally, from the previous slide, that direct forceful application of using those hand tools would have occurred for roughly about 84% of the shift as well. Cynthia?
Yes, if we look at this case, it's hard to change the WSIB's view that OA is secondary to age alone. But the evidence shows it's multifactorial. I mean, you look at this guy, he wasn't female. He was relatively young for a male to develop hand OA. We don't know about his genetics, but his main risk factor was occupational risk factors. If you go, I think there's one more slide, Trevor, if you could go to it. I like this quote from Johnson and Hunter. It says, OA appears to be the result of a complex interplay between mechanical, cellular, and biochemical factors that lead to a common end-stage pathology. As such, a different set of risk factors acting together may cause OA onset in any given individual. And we certainly see here with this patient that he had occupational exposures that contributed to his OA. And I think in these cases, it's the Ergo report that's invaluable. We may not be able to change WSAB's, calling things only age-related, but when you see an Ergo report pointing out his job and what's involved, I think it helps a great deal. And I hope his appeal gets accepted. And that's all I have to say.
Dwayne, any questions?
So you guys are ready? Okay, good. Thank you, Dr. Arnold and Trevor. Yeah, there's a few. So the first one is pertaining to genetics. Are there certain ethnic groups where OA may be more prevalent?
Yes, there are. They show that a lot of, I think I have it here, that the Japanese have less pain than Americans. And there is some evidence that Chinese have less pain as well. But when you look at genetics, they tend to say that it's a genetic variant, an ACAN, and an HFE that results in it.
Okay, thank you. So next question, is there any research on straight versus back bending thumb bracket genetics and how this relates to the injury and the force generation? I'm not really sure, but that's what the question was written. Do you guys understand that?
I'm kind of confused.
Is there any research on straight versus back bending thumb? And how does that relate to injury or force generation?
Back bending. I didn't come across anything regarding the thumb bending backwards. It was just on the abduction and the adduction of the thumb itself.
Yeah, when I look at genetics, they said, even for like ethnics and populations, they don't really have a good assessment of controls in the studies. And other than coming across some of the variants, they haven't really said much more than that with respect to the hand. And I certainly could look more into that.
Okay, thank you. Trevor, this might be for you. What would the required rest period be to potentially avoid repetitive injury? I'm assuming it's directed towards the hand and the thumb here.
That's the magic question. I mean, we really don't know. I mean, with almost anything we know, a work rest cycle, how much, how little, that's yet to be determined with almost any aspect of injuries as well as prevention. And I think something that definitely has to be researched in more detail because, and again, everyone's so different with individual susceptibilities, different hand size, etc., different tasks that you're doing, different occupations, the amount of force being exerted, the amount of pressure being applied. That there's so many variables that I don't think there's a magic number. The bottom line is, once you start experiencing fatigue, discomfort, that's when a great sign you need to take a break. I mean, for example, the one I can do is I was installing a new light the other day, working up on a ladder, my hands up overhead. And as per always, there was something that could have gone wrong. It went wrong. Arms were up overhead longer. I had to stop and take a break because the shoulder pain was getting so high. So once you start experiencing any sign of that beginning of discomfort, that's a good sign you need to take a break and allow some recovery.
Okay, thanks. That probably is very similar to this question. Are the principles of static posture / position or the lack of ability to regenerate applicable to static postures and position elsewhere in the body?
Absolutely. A prolonged static awkward posture is going to reduce blood flow to the muscles, the tissues, the joints, the cartilage, etc. No matter what part of the body it is, there's always the effect of static awkward postures on the reduction of blood flow and impingement of nerve supply going into the body.
Okay. Is there an amount of pressure that has been quantified to result in full compression of the cartilage, similar to the sponge being similar to a sponge being fully compressed? with no or minimal liquid remaining?
No, because that would kind of go against any form of ethics for research. Because and then cadaver studies aren't going to yield any useful results because the tissue is already dehydrated, and also would be in an elderly person. So no, there isn't any magical number.
Okay, Dr. Arnold, anything to add to that, or you good with that?
I have nothing to add.
Okay. Next question. Based on the findings, would the holding of a knife with the thumb remaining straight reduce the risk or the onset of OA symptoms? Do you understand what I'm thinking? Yeah. It would be without wrapping it around. That's my thought. I don't know.
Yeah, I mean, it depends on, again, sort of if we illustrated the thickness of the knife itself, whether or not there's adduction of the thumb happening.
Okay.
Would it be functional that way, Trevor?
I think so. Again, depending on the handle size, right? I mean, if you're doing very precise paring with a small knife, you're going to be getting the adduction. Something more larger with a larger knife, with a larger handle is going to make it easier. I do know that, like, when I'm in the kitchen chopping and dicing and stuff, I do try and maintain that almost like not quite a pinch grip at all. I've got my thumb on the side of the knife and my index finger more on the top of it. So there's less gripping going on, and it's more just transfer more to the wrist than actual the pinch gripping.
Okay, is there a relationship between vibration and the first CMC joint OA symptoms?
Well, again, the effects of vibration happen in almost any joint of the body that comes in contact with direct vibratory sources. So in our case study, the gentleman using the grinder, there was exposure of the hand, the CMC joint, which again will cause that cutaneous contractions of the muscles leading to fatigue, which then leads to reduction of grip strength, as well as reduction of blood flow and nerve supply on the tissues within the area.
Okay, just one more last one that was inserted. I'm assuming somewhere around when you guys were talking about research, it was asking how the data, if you knew how the data was collected.
For which part?
Like I said, it was about halfway through.
Yeah, because I mean, there's so many studies out there, right? So to know how they're collecting the data, it's not sure what study they're referring to directly.
Yeah, I can't figure it out. That's why I was waiting. I couldn't figure out exactly where that was, but okay. So that's that's it.
Perfect.
That's it for questions. Thank you, Trevor and Dr. Arnold. That was fabulous.